Good morning. Topic for today's lecture is on periodontal pocket. So I will be leaving it under the following contents. To start with, what is a pocket? So before formation of pocket, you should be knowing about what a sulcus is. Gingival sulcus is nothing but it's a crevice or a space between the tooth on one side and the gingival epithelium on the other side. So to start with periodontal pocket, what is a pocket? Pocket is nothing but it is the pathological deepening of gingival sulcus. So how do you classify periodontal pockets? You have different classifications for this. The first one is based on the morphology. It can be either a gingival pocket or a periodontal pocket. Gingival pocket is called a pseudo pocket because it is purely formed with the overgrowth of gingival tissues and there is no destruction of the underlying periodontal structures. But periodontal pocket is a true pocket where there is damage or destruction to the underlying periodontal structures. So the periodontal pockets can be further subdivided as suprabony and infrabony. Suprabony, as the name indicates, when the base of the pocket is coronal to or above the crest of the angular bone. If it is apical to the crest, it is called as infrabony pocket. Pockets can also be classified based on the number of surfaces involved as simple, compound, complex, or spiral pocket. Spiral pocket is also called so because the pocket begins on one surface of the tooth. It follows a tortuous course around the tooth and involves another surface. Coming to the other classifications, pockets can also be classified based on the number of or the nature of the soft tissue wall of the pocket. Could be either an edematous pocket or the fibrotic pocket. And based on the disease activity, you have active and inactive pockets. What are the clinical features? There is a signs in the pocket. The following clinical features can be seen when a patient comes to. There would be enlarged gingiva, bluish gingival margins with rolled out edges, a reddish blue vertical zone extending from the gingival margin into the alveolar mucosa, as well as you have a break in the buccolingual continuity of the gingiva. The gingiva appears to be shiny, puffy, discolored, with exposed roots. Gingival bleeding will be there. There could be exudation of pus, looseness and extrusion of the tooth, and development of diastema. So what are the symptoms? What are symptoms the patient complains of? The patient can have a localized pain or a sensation of pressure while eating, which reduces gradually, a foul taste, a radiating pain in the bone, and sometimes a gnawing feeling or feeling of itchiness in the gums. Also, a tendency to dig a sharp instrument in between the tooth, which gets the patient gets relief from it due to resultant bleeding. Sometimes patient complains of foul taste or bad breath, sensitivity to heat and cold food, and toothache in the absence of caries. So what are the pathogens or how does a pocket form? Various theories has been put forward on the pathogens of pocket formation, but the basic mechanism is when there is a bacterial challenge, gingiva inflames, there will be inflammatory cellular exudation into the gingival tissue, which cause degeneration of the connective tissue and fibers, proliferation of the junction epithelial cells. There is invasion of the junction epithelial cells by the PMNs, that is a polymorphonuclear leukocytes. More than 60% PMNs invade the junction epithelium. The junction epithelium loses its cohesiveness and it detaches from the tooth surface. Once it detaches, the picture shows the events, a series of events during pocket formation. So once it detaches, what happens? There is a deepening between the epithelium and the tooth, formation of a cleft. Degenerative changes will be there, which is more severe in the lateral aspect of the pocket. So more and more leukocytes or inflammatory cells invades the periodontal pocket. Finally, what happens is the pocket deepens and it becomes an area of plaque tension. So this is the basis of pocket formation. This picture shows a series of events in pocket formation. So what are the changes you see in the gingival wall and the hard tissue root surface associated with pocket? The gingival wall, you can see areas of chrysalis, areas of bacterial accumulation, areas of emergence of neutrophils. When the neutrophil and the bacteria interact, epithelial desquamation followed by ulceration and hemorrhage. So what are changes you see on the hard surface or the cemental changes? The first or the foremost thing what you see is formation of something called as pathologic granules. What are they? They are areas of collagen degeneration or areas where the collagen fibers are not completely mineralized. Some areas have increased mineralization. Some cytotoxic changes, what you see is from the bacterial end products or endotoxins. Then chemical changes because of minerals like calcium, magnesium, phosphorus, and fluorides. And sometimes a calcified layer will form which is resistant to heat. And you also have areas of demineralization, which is very closely related to hoop caries formation. So these are some of the hard tissue changes associated with pocket formation. Coming to identification, how do you identify pocket? Clinically, you identify the pocket by periodontal probing. A periodontal probe is a device which has markings which you insert into the gingival sulcus and check or assess the depth of the periodontal pocket. Coming to the treatment, how do you treat periodontal pocket? So after your diagnosis, you treat the pocket based on the type of pocket. As we've already said, if the pocket is of gingival origin or is a pseudo pocket, basically it is due to gingival overgrowth. The overgrowth is due to what? Due to the local factors, that is plaque and calculus. So main treatment option will be scaling and root painting, followed by maintenance. During the maintenance, there will be most of the times the pockets will shrink. But in case if the pocket persists, it could be treated by either gingivectomy, that is correction of the gingival overgrowth, or by gingival or gingivoplasty. In case if the pocket is an original or a true pocket, after the scaling and root planing, you reevaluate the patient. If the pocket is persisting, you can have 3 treatment options. New attachment procedure, where you regenerate the lost periodontal structures with bone graft or other membranes, or you remove the pocket wall. That is how it could be by surgical removal, by different flap procedures, or the other last option, if the tooth is very compromised situation, you extract the tooth, that is removal of the tooth side of the pocket. So once you remove the tooth or extract the tooth, the pocket is eliminated. Also, you treat the pocket if the pocket is supra-bony and infra-bony, as you've already said in the classification. The supra-bony pocket, again, the scaling and root planing, maintenance. If the pockets are persisting, it would be root planing or curettage, and sometimes advanced pockets leads to treatment with flap surgery. Infra-bony pocket, as we previously said, you have a bone destruction. So in that case, new attachment procedure, that is using various graft and membranes, or a combination of both can be tried. So this is the treatment of the periodontal pockets. So to conclude, as we all know, pockets are areas of plaque retention. The basic treatment option is doing a thorough scaling and root planing, eliminate the local factors, and check whether the pocket has subsided. If the pocket is a very shallow pocket, it subsides by itself. It's a deep pocket, the pocket might require advanced treatment options. Thank you.